I myself am a Boston-based neurologist. I actually walk the lines between industry and clinical practice. I clinically see patients largely in pain management institutions across the nation now with telehealth and teleneurology services, but mainly Boston-based. So the way I've taken it is first, disclosure. So as a pain neurologist, I have a natural bias towards caring for the disenfranchised. I'm actually pretty much a digital health specialist. I've created quite a bit of programs, software as a medical devices, population health tools. So I have a positive bias of using tech in the healing arts. Of course, I'm human, and therefore we have humanism in this process called medicine. And otherwise, I have nothing relevant to what I'm discussing. So we can move forward here. It's always important to know the practice setting in which you're in, because quite often the demography, the population kind of dictates how that natural history of the disease moves on. And this is when I was actually chief of pain management in Roanoke, Virginia. So located in Southwest Virginia, and we were in a pain management clinic. The patient I'm going to describe is a 61-year-old white woman. And her past medical history, well, she was obese. She had hypertension, high blood pressure, and she had type 2 diabetes. It's pretty common ailments that you see in this population. What did she come into my clinic for? Well, it's always good to put them in verbatim terms, especially when they're this short and simple. My whole body hurts. For how long? Forever, as long as she could remember. This is a common complaint that we get to see. What do we do? Well, we did a history and examination, you know, the standard course. Ask about the pain, when it started, what provokes it, what alleviates it, things of that nature. Did a physical examination, including a neurological and pain assessment. And what did we find? Well, we found that she had fibromyalgia. We'll talk about that in a second. She also had trigger points. These are particular points on her body that particularly are musculoskeleton driven, and their connective tissue gets inflamed. So when you touch it, it actually radiates outside of just the area that you're applying pressure. Sometimes you feel the taut band of muscle and so on. She also had some areas of inflammation on her body, including her right sacroiliac joint. So she had sacroiliitis. That's the divergence of the sacrum and the ilium, and so often associated with low back or often misplaced as hip pain. And the same thing with her right hip area. On her femur, the greater trochanteric portion was inflamed. So I developed a pain management plan. We gave her medications, milnacipran or Savella, and tizanidine or Xanaflex. So the first one is a serotonin and norepinephrine reuptake inhibitor, approved for fibromyalgia. Tizanidine is a muscle relaxant that actually works directly on the alpha receptors in the brain, so to reduce central tone. We also did some interventions, because that's what we do as a pain physician. Injected those trigger points, including those areas of inflammation, like the right sacroiliac joint and the trochanteric bursa, and then prescribed physical therapy. So what was the outcome? She tried PT for a couple sessions. That really made my pain worse. In fact, I'm being very kind here. She probably said, "Doctor, why'd you send me there?" It didn't help at all. In fact, it just aggravated everything. We had escalating doses of those medications I described, and we were almost doing injections every month or so, as much as the steroids that she could tolerate. And there was no ultimate improvement in pain. Would anyone say out there that this was a good case? I would highly doubt that. And so I actually kind of just facetiously put this case in here. This is everything a pain management physician should not do, hence the birth of this field. You know, that approach I just described is a very paternalistic perspective. I just found pain points and I inject them, and there was no real strong rapport with this relationship. So I want to take a step back. And what I mean by that, let's go into this in the true lens of pain management. Well, the setting is very important. You know, I glossed over it. I said Roanoke, Virginia, Virginia Tech, but and we're a pain management clinic, but it's actually more than that. We're an integrative pain management center. And this is not a marketing ploy. The center implies that there are individuals across different professions that are working together to alleviate pain in this center. And it's a center of excellence, meaning there's additional levels of competency that was derived to get that. When I talk about these other sections, there's an actual vision, mission, and values that put the patient first rather than the provider or first. You know, there used to be this adage that the physician is the captain of the ship. That's no longer the case. If you practice in that instance, I'm sure you won't last too long. It's really the patient. The patient is the driver of their own destiny. We're actually facilitators in this process, and pain management is a perfect discipline to apply this principle. In fact, when I assembled this team, everyone signed an agreement that agreed to the vision, mission, and values. Not only did they sign it, they actually helped form these types of principles. And the team composition is so vast. It's not just the physician. There's nurses, there's nurse educators, physical therapists, nutritionists, spiritual therapists, and you'll see some of the other elements of this case, how diverse this team actually really is. The patient is never just a 61-year-old blank, blank, blank with these medical conditions. They're more than that. They're inherent in a social structure. So their occupation is quite important. This particular individual didn't have occupation. They were unemployed, actually collecting disability for a number of years. In fact, that became a passed down occupation because their parents and grandparents, did the same. Family is very important, not just for genetic factors, but also finding what support systems people have. This individual had no one, actually, was living alone out there in a rural area of Virginia. BMI, yes, obesity is a huge component. Not only is associated with practically every disease out there, but also it influences mobility. Are they able to access your therapies because of very BMI issues and things of that nature? And then smoker, yes, this one was a smoker as well. And we'll get into specifics. Now, this is really where there's a fundamental shift in how you approached it. So there's the complaint, which my whole body hurts, and we hear this day in, day out. In fact, pain is one of the most common complaints that a primary care provider fields and triages. In fact, urgent care and emergency departments are overwhelmingly painful complaints. But beyond that, now that it's reached pain management specialists, we want to dive deeper. What are the functional goals for the patient that are reasonable that I could adopt and help facilitate? And that's what I call shared functional goals. So I remember the first time I asked this particular individual, this is a real case, by the way, the patient actually said mopping the floors, actually vacuuming and just doing laundry. So these household chores were her areas of special interest. If I imposed that, well, she wanted complete pain relief and she wanted excellent quality of life and measures outside of this, then I would not be doing her justice, and that would not be a functional goal. I would actually be supplanting the patient's voice in my management decisions, and that's not the way to practice. So very important to ask this question for all your patients, especially your pain patients. Now think about the history and exam. I glossed over it and I said, oh, it was your standard history and exam, but there's so many other features that can help inform your process. And that process is, one, establishing first a rapport with the patient, because this is a very vulnerable setting. This is maybe an individual that was otherwise extremely high functioning, integrated into society, was dependent on, and so on. Or there's features that led to her condition that are very sensitive. In fact, I go all the way down to childhood, development history. Was there any issues of sexual abuse? Was there incarceration, imprisonment? Was there any substance abuse issues? In fact, before I move on to the rest, there absolutely were problems in all of these. She had a very poor upbringing. In fact, she was in the foster system. She was sexually abused by people that were known to her. She unfortunately had some check fraud and was imprisoned for 5 years of her 40s, part of her life. And yes, she actually did abuse certain medications, particularly opiates, as a coping mechanism. Essentially, locus of control is extremely important. That, what I mean by that is, where do you drive your strength? Is it coming from external factors or is it coming from within? And that's what we call internal locus of control, or external. When she starts saying that I can't do this because of others or because of work or because of food or nutrition or other intake or the system or society, that's all externalizing. But if it was something from within, that's where you could really build the groundwork. And then this concept of learned helplessness. This is when, you know, you're on tough times and you're constantly getting bombarded with bad news, that becomes your modus operandi. That becomes where your starting point is. In fact, to the point where you're ruminating, you're obsessing, and you're catastrophizing. Nothing can go right, even when there are positive indicators that things could go right. And people often use the words, you know, I'm sick of this, or this is taking me to death, or, you know, I just can't do anything right, even when they have positive indicators from doing that. That shows that the process has been going on for so long, and it's going to be extremely hard to get rid of, because it's been solidified really in the brain. And there are some neurochemistry and pathways that we could actually activate to get rid of it. So that simple differential diagnosis, you know, it was beyond those fibromyalgia trigger points and inflammatory areas. She has chronic pain. And chronic pain in and of itself is a condition. It's a diagnosis. It should be treated as such. And people could use the, you know, more than 3 months or more than 6 months to define it. But there is something that physiologically, structurally, that changes in your body when you have constant bombardment of pain signals, essentially. And then there's that series of learned helplessness. That itself is also a diagnosis. The reason why you recognize it is not to create a laundry list of diagnosis, but there are very targeted treatments that we could go at. So when I talked about that pain management plan, which was simply medications, injections, referral-based therapy to physical therapy, you knew that that's not the right approach. That you have to have a holistic model. You have to have tools that empower the patients. You know, when you almost reduce the encounter with, here is a pill, or here is some exercises, that is perceived by a lot of pain patients as being minimalistic. And this doctor does not care about my disease state. In fact, does not have the answers. And that is why pain patients often feel mistrust with the healthcare system, often have gone through several physicians, be it primary care, neurologists, rheumatologists, other pain doctors, just to find someone that could connect or relate or validate. You'll often hear this term, validate their disease process. So quite important in that sense. And you have to realize that when they develop this pain situation, let's say, you know, I want to spare you the details of this particular case. Someone gets injured at work, lifting something pretty heavy, and they have low back pain. The circumstances around which that developed, the environment in which it enveloped, and I'm not just talking about that mere physical environment. You're in a work situation, you have colleagues around you, you're being scrutinized because you're doing your job, maybe your supervisor is there, your family dynamics, people are dependent around you, you might have some financial stressors because, oh, you got to pay the bills, right? And you might have children, and they rely on you for emotional and moral support and being there to help them with their homework and other types of assignments or preparing their meals or whatnot. You might have dependent parents or grandparents that are going on there. All of this actually helps shape how you perceive pain. So pain is not that simple pathway that you've learned in the first couple of years of medical school, that there's a spinothalamic tract and its synapses here, and it might have some connections off of limbic areas and things of that nature. It's beyond that. It's beyond a simple track. It's beyond connections with limbic areas. It is circuitry that changes, and the circumstances around it are just as important as the initial event. I know when we do history taking, if it's a car accident, we find every mechanism possible. How fast are you going? Were you a passenger seat? Was there loss of consciousness? But did you ever take the time? Well, were you going through any other major stressors? Well, yeah, I was going through a divorce, and I was actually very depressed, and I wasn't eating, and I lost weight, and all of these other aspects. Those are just as important as the physical dynamics that led to the painful state. Reason being, one is because those could be prognosticators. Is this pain going to persist for longer than normal? Because there's a natural healing process for most painful conditions. And when it goes beyond that, hence the term why we call it chronic pain, that's chronic because of a reason. You don't always have that to have that initial stimulus, that initial driver or motivator for pain for it to be chronic. It's called sensitization. It's when the brain is actually always bombarded with those pain signals, it's almost become used to having that level of pain signals. That's your new threshold. That's your new baseline. And so that's what a lot of people, you'll hear them to say, I always have pain. It's baseline pain. And I could still have flare-ups and fluctuations on top of pain, but there's this level of baseline pain. If you don't recognize that, you can't relate to patients and you can't address some of the root causes. You know, previously I talked about developmental history and sexual abuse. Well, these are factors. You know, it's been shown that if, particularly in women, if you have sexual abuse in early developmental stages, and of course, even in latter stages of life, then you could have more persistent or chronified pains. There's more affective or emotional components to it. There are more triggers, you know, related to it, and it's harder and more resistant, essentially, to treat. And so it's something to consider. Now, in this particular patient, what do we do? Well, we took a very patient-centric approach. Not only do we remember, we identified those shared functional goals, the entire team recognized that. So when she saw any member of our team, she wasn't asked again, hey, what's your pain scale from 1 to 10? And which is a meaningless number. I've almost stopped doing that around a decade ago. We actually asked, well, how much are you able to actually vacuum or mop or clean your house, or those other things that she listed as priorities in her condition. So how do we get that? The management plan involved some physical rehabilitation. So when I say that we referred her to physical therapy and she was fed up with it, I'm going to say this is the vast majority of patients that you would direct to physical therapy without going the proper process. And what is the proper process? Well, empowering patients. So there are measures that patients that can do themselves. And these are simple types of exercises, isometric, volumetric, and things of that nature that you could get, and they're available on the internet, and that you could provide them to patients. That is much more empowering than imagine a chronic pain patient who is so devastated, who went to your office, now has to drive and see a physical therapist to have a 30-minute session. First of all, it's a meet and greet and assessment, and then it's going to be treatment evaluations just for insurance to cut off, and they're going to be like, wait, that was not really helpful, right? Also, when they have pain, when they do particular exercises, do you think they're going to go back to them? No, you got to actually make it a comfortable process. So, and actually set the pain, separate the pain that is harmful, or pain that is just actually fear, but it will not cause actually further injury. And when you have that latter type of pain, we lead to fear avoidance behaviors. Have you noticed that individuals, you know, with particularly neck injuries, they actually can't move from one direction to the other? And that's not because they have oftentimes a physical mobility. They are fearful of actually making this because perhaps someone in the past said, oh, you'll have a spinal cord injury and you'll always remain that way. These are fear avoidance behaviors that if you catch them early, you can prevent them from forming. If they've already formed, then you could, in a very safe, gradual type of way, you could show, nope, certain movements are actually permissive and you're not going to cause injury. In fact, they're going to be therapeutic for you because biomechanics is all about pain management. When you stay in a particular posture and you're not building primary and secondary muscle groups, though you're going to have a whole musculoskeletal cascade, and then joint cascade with arthritis, and then neurological compromise too with the nerves because they don't have mobility and freedom in biomechanics. So it becomes this cascade that you're going to avoid. So that's how we started off with this patient. And then as she gradually met the limits of home types of exercises and had better pain control, then you could introduce more physical therapy types of approaches, aqua therapy, particularly in water settings or heated type of settings, and so on. It's a gradual process. The next process is called mental health. And I'm not talking about a simple referral to a psychiatrist, turfing, so-called, and lo and behold, this is not my issue. Psychiatry will deal with anything that is associated with your mental health, and I'm strictly going to treat you for pain. That's not the approach. After all, we have the tools. We should have the tools to be able to take care of these types of patients. And there are many ways to do this. So you yourself is actually establishing some sort of mental health rapport. They're vulnerable. They're revealing a lot of their past history. They're obviously, undressing in front of you when you're doing the examination, and they're emotionally and effectively naked because they're revealing all these pain points right there in that 1 hour, 30-minute session in front of you. You are their counselor. In fact, you might even be their most trusted type of counselor in this type of setting. But sometimes you need folks that could carry on that type of activity. So we had peer counselors, other people who have gone through pain management process. We've also had specialized psychologists who are trained in cognitive behavioral therapy. A lot of times we need to work on restructuring how the brain processes pain. In fact, fibromyalgia, all of these somatization types of disorders, chronic fatigue syndrome, central sensitization, these are all exaggerations of pain impulses that happen on a neural basis. These are subconscious, of course, exaggerations of pain stimuli, so they feel very heightened. I've had fibromyalgia patients, literally, you just touch their skin. They have incredible amounts of sensitivity and they jump. Imagine doing a physical examination on such patient. But that's not something psychologically embedded. That's because their thresholds have changed. But now there's a way to do cognitive restructuring. That is now rechanging the reference point of what pain is, and also reducing those fear avoidance behaviors. And we could do that through telehealth platforms nowadays. Then there's something called cognitive rehabilitation. This is where you could actually have digital applications that could support them, reward them, incentivize them when they make good choices, and actually could have some penalties when they don't make good choices. And what are we talking about? These could be financial rewards. These could be access, to things that they like, some freebies or prizes or things of that nature. This could be through feedback. If you're monitoring their progress, you could present them, oh, well, you're doing better in one area or another. And how does this do this? Through cognitive behavioral therapy and in something that we called incentivization. There are these types of programs to do that. It's extremely important. And then there are integrative measures. And these are the fun things, like pain nutrition. Believe it or not, what you eat can influence your pain levels, particularly if you divide pain. So I've been using pain very loosely, but there are various types of pain. Inflammatory pain, neuropathic pain, visceral pain. Like if you, have a surgical incision on one of your body parts is very different than if you have chronic arthritis, which is very different than if your nerves are injured. And they actually should be approached differently. And on a nutrition level, we have certain foods that are pro-inflammatory and anti-inflammatory, including supplementations that you could take to promote that. So having gone through a pain nutrition program is quite important, not to mention the bystanding effect of having overall good nutrition and the lower BMIs associated with better pain recovery. Then there's something very important called therapeutic neuroscience education. I'm sure not many of you actually on this line have heard of this, but this concept is pretty simple. And it could be done by anyone, and I love when it's done by physicians. It is actually describing the pathways that are involved in pain generation, the ones that you've learned in medical school, but actually putting it more in a visual format and saying, when someone stubs your toe, this is what happened. Those free nerve endings get those impulses. It goes down the foot, into the spinal cord, goes through the brainstem, eventually into your brain. It gets processed there. That's really, how you feel it. It gets connected to other parts of your brain and so on. And then you start introducing, well, there are other things aside from that thing that stubbed your foot that influence how your pain is. Have you noticed that if you had distractors, or if someone was touching you at that site or massaging it, or if you had cold or heat or other sources, that your pain is not as great? Well, that's because it's a band. It's a hose pipe, and there's a certain amount of fluid that could go through, it's kind of a gateway. That you could call it. And there are ways for you to discuss it. And then you could say, everything I've been talking about so far is the hardware. These are nerves and impulses being transferred. Then there's the software. There's these gates and controls, and then how memory and how positive emotions or negative emotions can open and close these types of gates, which are more, software associated or modulatory. And these 20 or 30-minute sessions can have a tremendous impact because 1, they know how pain is generated. 2, they know all the influences about pain. And 3, they could directly connect it to their journey and their experience. So the next time they have a pain flare, they could be conscious. This is a level of mindfulness where they do a body scan. Well, actually, my pain is exaggerated because I have this stressor going on and this X, Y, and Z. Maybe if I modulate those, my pain levels might go down. And so that's returning locus of control back to the patient. They're more self-aware, more self-actualized through a mindful process. Extremely important exercise. And then one other measure that we chose to use in this particular patient is something called pet therapy. Now we're based in, there's reasons why I mentioned she lives in a rural setting. She's alone, so no one's dependent on her. No one's watching her as well. There's not much level of social interaction and things of that nature. I give her incarceration story or developmental history story, foster child. There's always attachment or abandonment or these social relationship types of issues that goes along with it. And we're in rural Virginia, and she happened to have a farm before and used to raise animals, but hasn't for 20 and 30 years. Well, I don't know how many of you have heard about goat yoga, but these are, using miniature goats, I'm sorry, particularly these Nigerian dwarf ones. And they're about yay high or so, but they actually serve as stabilizing forces when you're doing yoga poses. So additional weights, they're also fun and friendly, and you can socialize with them. And so all the literature points that these are wonderful exercises. Not only is it going to be helpful for this particular patient from doing goat yoga, but she'll also be taking care of the goat because she has the resources to do it. She has the landscape and the farm and that background and so on. So she'll actually have some animal that is dependent on her. And that's actually very therapeutic, probably just as much as the movement exercises with yoga therapy. So lo and behold, outside of that outcome, which was a facetious, type of course where there was PT alienated her and there's no improvement in pain. No, she had something, and these are the magic 2 words in pain management: functional restoration. What do I mean by that? No longer is the goal of pain management elimination of pain. Of course, if we could achieve that, we would. Many acute pain cases, we can. Chronic pain cases, because I told you how it's embedded into many of our substructures and circuitry, it's sometimes impossible. So if you're chasing an impossible goal, then that's an exercise of futility. And therefore, what really should be the goal is a functional restoration. And whose functions are we trying to improve or restore? It's the patient's functions, as long as they're reasonable, of course. And that's exactly what we achieved. She was able to do all of her household chores. She actually had a new friend, the dwarf goat. She was much more physically capable and had a great amount of resiliency. And I just saw her demeanor changed. And here we took a very distrustful individual of healthcare systems who has been turned away and disappointed or given false hopes or promises I could eliminate your pain, or did not even connect to what her painful condition was and how it relates to her real life, her application, her functions, to a state where she's independent, has now the cognitive ability and social abilities to engage in meaningful relationships, and actually became an ambassador for this integrative pain program. So I wanted to really use that case to highlight the power of integrative pain management. And then I'll use the next half hour to field your questions, discuss the journey, what my personal motivators were to get into this particular field, and whatever else comes across. So let me exit out of this over here. I'll keep this slide. I'm also always available for questions. And let's see if we have any particular questions. Oh, there's a ton. Very fun stuff. So let's start off with after the introductions. Okay. So what initial workup should a general neurologist perform for these patients before referring to a center like yours? Oh, great question. It's a very practical type of question. A general neurologist, really should employ many of the same principles as a pain management physician. That means including a thorough history taking, a thorough neurological examination. But I'm going to say neurologists in general have a tendency always to localize, right? Those are like the 3 key terms, like in location, or real estate. And oftentimes they're unsatisfied because when pain becomes chronic pains, it's actually not localized, it's generalized. It becomes impregnated in multiple areas of the brain and areas of the brainstem, essentially, and it has multiple triggers or motivators. That's another thing. Neurologists love, when there's a single entity, there's an epileptic foci, there is a stroke, ischemic foci or hemorrhage, associated with that. There's even generalized conditions, but they want the same pathway. Oh, that's a neuromuscular condition causing like myasthenia gravis, causing, generalized weakness. There's a lot of discomfort when we're dealing with fibromyalgia or multifocal pain conditions. So actually it's more of a thought process. Be open that there are many generators, be open that chronic pain exists as its own entity, particularly when it's been there solidified for a long process and it's recalcitrant to some degree. And be open that it's not always a hardware issue. I'm talking about a lot of those software, and there are a lot of soft influences in developmental history that could influence pain. So great question. I was wondering how satisfied pain patients are with digital health tools. Oh, fun question. I'm assuming that there is an element of social physical interaction that helps in pain alleviation. Yes, I mean, silver lining with the whole COVID pandemic is that more people are adept to adopting non-contact technologies, including digital health. In fact, I've had, as an industry person, I've actually designed a lot of clinical trials where I would say, oh, that patient population would not be adept or adopting of digital health. No, I've had the chronic paranoid schizophrenics use smartphone application data that would monitor or track their geolocation. No, I think a lot of times these obstacles and impasses are in our own heads as prescribers or soon to be clinicians, essentially. People, as long as you connect to them, what is the outcome? How is this tool actually going to help improve their quality of life, their functions? If you make that connection, then they'll use it. And then if you reinforce it as well. I have seen folks that, get offered a digital health tool, but the next practitioner they see have no credence in it. I was like, oh, you're going to try one of those silly things? Here's another med, or here's an injection. Unfortunately, they treat it as almost a second-class therapeutic, and it shouldn't be. We really should putting on the same footing. In fact, they've gone through all the regulatory hurdles of being proven themselves in clinical trials and by regulatory agencies and so on. So great question. How about neuromodulation and spinal stimulation? Yeah, how about them? It's a fun field. It's obviously has been an emerging field for 25 plus years. It's not in its infancy. It's well established. What we're talking about are stimulators, particularly spinal cord stimulators that activate the posterior columns and dorsal columns, and thereby may modulate what pain signals, eventually reach the brain. And they have very clear-cut type of rationale for its use. So if you have complex regional pain syndrome, which was a autonomic type of pain, that's a neuropathic type of pain of usually a particular limb, that's great. So when you have a single focus, and you could isolate it to a dermatome or something of that nature, use it. What are the failures? Aside from all the technical failures that any interventional spine physician can tell you, it fails because it does not address the whole gamut of pain and pain generators and what keeps it going, and the psyche and the nutrition, the spiritual and the intellectual, and the physical rehabilitation and all those other components that go along with the pain process. So I treat it just like any other modality. This is called multimodal care. What other kind of specialty physicians do you work closely with? Well, for example, PM&R. Yes, absolutely. PM&R, physiatrists, their whole specialty actually came from functional restoration. What do they really do? Sometimes I ask my colleagues, because there's a lot of confusion in PM&R. What in essence are you? We could say a neurologist treats CNS and PNS conditions, right? Clear. Give me some examples, epilepsy, seizures, peripheral neuropathies, fine. What does a PM&R do? Well, I love that response. They're like, actually, all we do is physical restoration. And if you answer in that fashion, you understand what PM&R does. And a lot of chronic pain patients need physical restoration, and they need the services of PM&R. So absolutely, that's one of them. Other specialists, I already mentioned psychologists, nursing specialists, clinical nurse specialists, nurse practitioner, registered nurses, educators, health educators, peer coaches, the whole gamut of all types of physicians, primary care, neurologists, rheumatology when it comes to autoimmune diseases, some fibromyalgia, overlap, lupus, rheumatoid arthritis, those types of things. A lot of surgical disciplines too. Believe it or not, there's a lot of abdominal pain. And where does that come from? They often do see GI docs and general surgeons, or those that specialize in abdominal type of surgery. So I've developed clinics surrounding GI associated pain, musculoskeletal pain, women's health issues. There's a lot of perineal pain and pelvic associated pain. There's urological pain, so men's health issues, so your prostate or the urethra or testes. I mean, frankly, pain is ubiquitous, and that might be why there's so many fields that could go into it. And I have a side about that, but I'll talk about that later. Okay, cool. What pain management niche do neurologists fill? Oh, great one. And there's actually a paper in neurology that I reviewed that kind of addresses this to a greater degree. It's a good aside. So the birth of pain management actually came from anesthesiology, and that's why the majority, the lion's share of current practicing pain physicians have anesthesiology backgrounds. And fortunately, unfortunately, a lot of program directors actually have that background, and they're housed in anesthesiology departments. And why is that the case? Well, what do we have available to us? We had perioperative pain. And who was best able to use drugs, and particularly those that are acting on operative patients? Anesthesiologists. Who was able to do those blocks, who was able to do all of that. So the birthplace came from a very perioperative setting to chronic pain, outpatient. I mean, when's the last time you had a great conversation, with your anesthesiologist going a procedure? No, it's usually, hey, if you have an allergic response or anything of that nature, good luck, and I'll see you on the other side. No, it became to outpatient practice, and they required more cognitive specializations. And so that's why, neurology and PM&R and even emergency medicine and psychiatry and other types of fields kind of came onto place when it became more of an ambulatory type of setting. And it became more, medication management and less of these interventional type of components. And it became more rehabilitation than acute pain services. So you'll see some divisions: acute regional pain, which is still anesthesiology dominated, and some more chronic pain or general waste basket type of pain, which could be any specialty drawn. I'll talk about education pathways in a second. It's a one-year fellowship, ACGME accredited, of course. You could come out of the majority of disciplines. And why do I think neurology is well suited, aside from my natural bias? We look at mechanisms, pathophysiology, generators when it comes to pure neurological diseases. We look at localization, we look at in those pathways, and neurology has become more of a field of interventions too. So we kind of mediate both of those lines. That's why I like this field. But that's not to say that any other trained specialty can't take this on. What are your thoughts on the use of acupuncture for pain? Yes. I'm a proponent for the limited use of acupuncture where the level of evidence exists, and I've been part of many clinical guidelines and systematic reviews and meta-analyses on this function. When people say that they're a holistic or integrative provider, it does not mean that they've abandoned all scientific rationale in the method. It just means I'm open to considering those options provided the evidence exists for it. In fact, I put it at the same footing as traditional therapeutics, interventions and medications. That's what I mean about it. Yeah. Have you considered already work with osteopathic physicians in your own practice to address certain physical aspects of pain, trigger points like OMM and OMT? Exactly. Oh, absolutely. In fact, I maintain a faculty appointment through Western University, which is a very large multi-campus university for osteopaths. Absolutely. I'm going to be frank here. There is quite a bit of rich history in osteopathic medicine that led to its generation and its differentiation from allopathic medicine, particularly using osteopathic manipulative treatment or manual medicine. However, a lot of that has, through a very reductionist process and in this process of assimilating into allopathic worlds, MD worlds, those lines have become blurred, and you can see that with common GME programs through ACGME and so on. So there's this lost art that was the real basis for the genesis of osteopathic physicians. I love that people have that background. I think very few of them now actually continue that in real practice. And pain management would, of course, welcome that. That would be an asset. Do you work in an inpatient setting at all? Yes. The beauty is you could be outpatient and inpatient. So far, I've been focused heavily on outpatient. Inpatient, I think there's a tremendous need. So in most large tertiary medical centers, there is some sort of pain management service line or pain management team. And this could be actually nurse ran or full physician led comprehensive therapy, services. I actually have been responsible for developing a couple of those and have practiced in many. MGH, for instance, has a very robust one that has advanced nurse practitioners, that has physicians from anesthesiology, neurology backgrounds, that has nurse educators, that has a very comprehensive type of team. So yeah, I do that as well. Thank you for modeling the best way to treat patients with complex pain conditions. You mentioned behavioral therapy to potentially change learned pain pathways using telemedicine. Are there any digital resources available to patients to reinforce this behavioral therapy, similar to giving patients their own physical therapy exercises for the sense of empowerment? Yes, there are actually quite a bit. I have to be agnostic to the company in this call. I actually have some relationships with certain type of companies, but I would do your own diligence and look at CBT, digital CBT. Look at the levels of evidence, for them, particularly for painful conditions. Some are generalized. You could use CBT for everything, any ailment, and some are specific for pain type of conditions. I would also look at the ones that have pain tracking, have incentivized types of systems in it that give feedback, biofeedback and so on. So I can't mention specifics here. Let's see, what kind of research are you involved in? Oh, all gamut. So the beauty with pain management, in fact, let me just give you a step back. Why did I enter pain management? I remember I was a neurology resident, year 2, PGY 2 in the Cleveland Clinic. It's a categorical program, so I did all my 4 years there. And I just noticed that it was such a disenfranchised population. Oh, there's that pain patient again, coming back to the emergency department for the 5th time this month, or being readmitted, or outpatient, on this opiate prescriptions, on this level of opiate medications and so on. I felt, it's almost some sort of kindred component, but altruistic and also enigma that intrigued me. First of all, the science can be further developed. Applications are just emerging. Multimodal treatments are the way to do it. It's disenfranchised, so your ability to make impact is great. It's fulfilling. I'm going to say injections are the best in the world. You imagine someone who couldn't walk for years because of chronic low back pain, and you do one epidural steroid and they're off your gurney. Essentially, that is one of the most gratifying things. But just as gratifying for me, I'm not one that needs immediate gratification. It's someone that had decades-long experience dealing with chronic musculoskeletal pain, and now they could do something that they haven't been able to do for that period of time. If you're gratified by that whole spectrum, pain management is, definitely for you. Challenges, I'll talk about those as we move on. But it was that caused me to go in. But then I thought about my father's experience. So the reason I got into neurology is my dad was in the US Army. He fought in Vietnam, had Agent Orange exposure, and had a basilar artery stroke. So a brainstem stroke that left him in locked-in syndrome for over a year at the VA hospital. And I was quite young at the time, but I got exposed to medicine and the powerlessness of neurological diseases. And this is actually pre-TPA. So there really was no intervention that could be done at that, and certainly pre-thrombectomy at that time. And that got me into neurology. What got me into pain? He actually survived, had some dysarthria and hemiplegia, but what was disabling him, what was troubling him, what was keeping up at night? The central pain that stemmed from it. And I found that fascinating. You could go through so much insult and injury on a neuronal basis, but what's keeping you from full functioning is pain. That really drove me into the practice. So if someone has that type of personal experience, I'd love to hear it. And that's a great motivator for moving into this field. Let's see. Oh, research the whole gamut. So everything from full-fledged phase 3 clinical trials of novel molecular entities to developing actually new digital therapeutics. So putting in computer-based physical therapy that actually does video motion capture, so you don't develop fear avoidance behavior on certain range of motions, and some other types of things. I'm involved in all types, all the way to basic science, neuroprotective factors for its generation. What should we tell patients who are initially worried on the benefit of behavioral therapies for pain or non-medication-based therapies? I'm going to say, frankly, everyone's worried about medication options, but also the efficacy, so its ability to actually make an impact. So they're not worried about usually safety or tolerability of non-medication. So you have the opposite type of conversations. First and foremost, have confidence in what you are talking to your patient about. If you say, this is just one of these things on a checklist, here's a paper, this might work, this might not, what are your chances of success? Absolutely minimal. I mean, you might have the nocebo response, actually quite the opposite. You actually might have a negative effect on their pain profile. How you portray something, it's almost, frankly, you are the gatekeeper for any prescribed technology, intervention, whatever medication that's out there. And so if you're going to prescribe it, you should have full faith in its efficacy, and of course, fully inform the patient in it. And you should not give more credence to one or the other. If you pose this as, hey, how did you develop your pain? It wasn't just simply X, Y, and Z. By the way, anyone that has a 20-year low back history, no one could come up with a single reason why they had it. Even if they had a work-related injury or whatnot, they're going to say, oh, plus I strained it doing this, someone kicked me doing this, I fell down doing this. And this has been a series of things, and you can't dissect every part of it. You have to accept that it's been generated through multiple pathways. And once they have that level of acceptance, and you go through the pain pathways through therapeutic neuroscience education, it's very logical for them to see, well, I got to also tackle it in a multimodal approach because it was built in a multimodal manner. And so there are many ways to make this very palatable to patients. Okay, could you go into detail about the education pathway through neurology leading to pain management certification? Yes, so you must complete your neurology residency, and just about in your final year, you apply for the ACGME Fellowship in Pain Management. And it's a match process. For the last several years, it's actually been part of the match, NRMP match, I should say, because there's San Francisco and so on, which is this not a part of. And I'll give you, the real situation. You're competing, if I presume most of these are neurology-bound individuals, you're competing with other specialists for these spots. So anesthesiologists, PM&R, maybe there's some psychiatry that goes into it. I even had some radiologists, internal medicine, particularly those that have palliative medicine training, sometimes go into this type of field, and then neurology. Those are the major players that participate in it. But you have specific assets that the anesthesiologist in particular does not, or even the PM&R physician that does not. If you take advantage of it and the way that you portray it. So I do a lot of counseling on this, and that's the cognitive processes. You're very familiar with multiple medication management and its interactions. You're very familiar with localizing lesions, conveying information to other teams, working in collaborative structures, and so on. This is where the downfalls come in, interventional skills. By the way, that 1 year, you're going to learn how to do everything from simple blind injections to image-guided ones using ultrasound or CT or fluoroscopy, to all the way to spinal cord stimulators and modulations, perhaps even pain pumps, so surgical implantations. And so there's always on the back of the mind, whether they're neurology trained or anesthesiology trained program director, they're going to say, does this person have the chops to navigate the interventional waters? And this is where you're going to have to show, hey, if you're serious about this field, I've done rotations in it. I have positive references and reviews that that I manage those types of patients well. I'm good with manual dexterity, psychomotor skills, things of that nature. If you haven't delved into it, or you've only delved into it from a very cerebral cognitive fashion, then that gap, that void remains, and it's a vacuum. And unfortunately, someone who does not have that vacuum will get that spot. It's highly competitive field, by the way. Great question. And then I'll go just a step beyond that. So after you complete your fellowship, you can do your board certification. And the board certification is this for neurologists is essentially the same one as for anesthesiologists, the same examination. It's just administered by the ABPN, the American Board for Psychiatry and Neurology, rather than the ABA, the anesthesiology counterpart. But it's the same board, and I used to sit on their exam writing committees and so on, which is a good thing because you do have some representation of neurology focused questions, some PM&R focused questions, anesthesiology interventional focused questions. And there you go. And then with changes in board certification, which you could look up, you need not anymore retain your primary board certification, which is neurology. You could always, you could opt into a track, which is just doing recertifications for your subspecialty, which in this case would be pain medicine, it's called. How does insurance coverage work for some of these additional treatments, such as pain nutrition? Oh, I love this. I haven't mentioned any names here. Roxana, fantastic question, because you're getting into the practice of medicine and reimbursements. Yes, so a nutritionist can bill for nutritionist time. In fact, I partnered with a nutritionist in Virginia Tech, and we created a whole proprietary pain management pathway that was reimbursable. Otherwise, this is a charity service, and that's not sustainable in any healthcare system, particularly in these trying times. So you could bill this as nutritional counseling, nutritional services, if you incorporate a nutritionist into the program. And it need not even be one-on-one. You could actually have group-based, either education or group-based nutritional therapy. And there are nuances that go into it. This is a billable procedure with its own CPT code and reimbursement. Yes. I got a warning, which is now 6 minutes, not 10, which is good. What are some of the challenges of being in pain medicine? Would there be an advantage to being dual certified in anesthesiology and pain medicine? Yes, okay, so challenges first. Challenges are that you are, as a neurologist, you are amongst the field that is anesthesiology dominated. You have to prove yourself on an interventional level, aside from every other facet that's going on. That's an accepted challenge. However, there are even some financial challenges. There are some studies and literature to look at, well, salary distribution if you came from an anesthesiologist background versus neurologist, even after going through ACGME pain management. So there's some inequities that are going on. Challenges are probably advocating for your field. And actually, that's the article I'm talking about in neurology. I focus specifically on neurology trained management physicians. We have actually a table in there that looks at all the academic centers that have at least one neurology trained pain management physician. If those are probably going to be easier as far as gatekeepers go to enter, those have programs to do it. As more departments are becoming pain medicine or management standalone or outside of anesthesiology, I think that will change. There are some pains dealing with patients that have learned helplessness, intense amounts of biopsychosocial stressors, a lot of psychopathology in the chronic pain type of world. There are very high demands. These are high healthcare utilizers. There are very complex chronic comorbidities. And so it requires an individual that could do that. Essentially, this is not urgent care type of visits where you have one ailment in front of them and that's all I'm going to focus on, and it's symptomatic type of control. Good pain management providers look at things in holistic, and everything is interconnected essentially. There are other challenges when it comes to opiate-based prescriptions and abuse associated with that. It's a unique challenge to pain management because you get more scrutiny. However, all studies shows actually the ones that were responsible practitioner-wise for abuse were not pain trained. And in fact, the pain trained ones are much more conservative in their use and know when the appropriate timing comes in place and documentation and safety measures. In fact, I used to give a talk at AAN about safe and appropriate prescribing of opiates. It was one of the workshops. So have a look at that. That's a good point. And then the advantage of being anesthesia and pain medicine, I think you have an easier gateway. Your network will be stronger. You might be more interventionally trained or regional anesthesia trained and things of that nature. Yes. Can we get a particular link to a paper? Yes. So whatever papers I've mentioned, I could share that. And I'll share it with the AAN organizers so they can distribute it to everyone who's signed up for this meeting. I think we just have a couple more minutes left, so I'll field any question at this moment. But I do want to leave on one note, because I saw the roster. This is everyone from MS1 to MS4, and actually even some interns internationally are in this call. We need more neurology trained pain management physicians, and that's not just being because we want to establish a neurology pain kingdom. It's because we possess the specific skill sets for this emerging and transforming patient profile. People getting older, more sickness, more comorbidities, living longer with cancer, living longer with otherwise progressive fatal diseases. What accumulates is all of those symptoms, including pain. In fact, I could say the same argument for palliative care. That's another field that that we could have another discussion on, but it's quite important to discuss those types of fields. There's an unmet need out there. We have specific skill sets. There are some challenges for us to achieve it, but it's incredibly rewarding at the end. Financially as well, it is one of the probably the best paying of physicians that graduate from a subspecialty in neurology. I think others would be interventional neurology or interventional radiology, because the higher reimbursements associated with interventions. So financially it's rewarding, altruistically, patient profile, it's rewarding. You get to practice in a variety of settings. You could be in ambulatory settings, inpatient settings, collaborative settings, and so on. And there's a need everywhere, you know, frankly. Yeah. Great. So I think we're just at the minute mark. Looks like there is a link. Please, you know, fill out this assessment to give you feedback. It's been an incredible journey. Thank you so much. Take care. Oh, sure. Actually, what I'll type is my email address onto this. I welcome direct emails from anyone on anything. Yes. Perfect.
Thank you so much for your talk today. My mouse just disappeared, not sure where it went, but thank you again. If you have any questions, feel free to email me as well. My email is ggates@aan.com. So thank you so much, Dr. Lakhan. I learned a lot, and I'm not even in med school. So thank you so much.
Absolutely, you're most welcome. Yes.
And take some time to fill out that assessment and let us know how today's talk was.